2022. So without wasting much time, I hand over to Deepa Tangamani Madam, who is the consultant and also um, in charge of Clinical Research Committee. Over to you, Madam, to
Thank
take
you.
over.
Thank you. Today we start with every month. The plan is like one case per day per month. The first case will be presented from the Kasturba Gandhi hospitals. And the coordinator for this is PG is a final year PG, Dr. Tendral, and the mentor for Tendral is Dr. K. Priyadarshini. So with this, we will move on to the presentation. I'll just share the Tendrils presentation screen. So her case, recent case, she is planning to discuss. Can you able to see the full screen?
Yes,
Tendrils?
Madam.
Yes,
Seen.
ma'am. Yes, ma'am.
Okay. So the first case is from Institute of ISO KGS Replicants under the guidance of Dr. N. Nagarajan, Director of Social Obstetrics, and the moderator for mentor for her is Dr. K. Priyadarshini. So the presenter by the Dr. Tendral. So over to you, Tendral. Tendral, can you able to see the screen?
Tendral, please switch on your
Yes,
mic.
ma'am. Good evening.
Yeah,
Yes, ma'am. Good evening, ma'am. Shall I start, ma'am?
yeah, please start.
Mrs. X, 25 years primary, wife of Y, homemaker belonging to Kupuswamy socioeconomic class 4, coming from Chengalpattu, came to KG casualty on 25/4/25 at 4 p.m. with 9 months of amenorrhea. Her LMP was 8/8/24, EDD 15/25, gestational age 37 weeks plus 1 day. Time of admission at casualty 4 p.m. on 25/4/25. Booked and immunized at Kelembakam UPHC. Patient came with chief complaints of draining PV since 1 p.m., 3 hours after PROM.
Sorry.
Yes, ma'am. Is she presenting illness, ma'am?
History of presence. Next slide. Okay.
Yes, ma'am. Is she presenting illness? Complaints of draining PV since 1 p.m., which means 3 hours. Complaints of lower abdominal pain on and off since 3 p.m. No issue of bleeding PV, no issue of fever, no issue of breathlessness and palpitation, fatigue, no issue of burning micturition, no issue of increased frequency of micturition. Patient can able to pursue the fetal movements well.
Next slide.
Next slide, ma'am. Menstrual history, attained menarche at 12 years of age, regular menstrual cycle 3 to 4, 30 days cycle, changes 3 to 4 pads per day, not associated with pains or clot. Her LMP age 8/24 and EDT 15/25. Marital history, marriage since 1 year, non-consanguineous marriage. Obstetric history, first trimester, conceived spontaneously after 1 month of marriage. Pregnancy was confirmed by urine pregnancy test at Kelembakam PHC. 45 days of amenorrhea. Her first dating scan was done at 7 weeks and pregnancy was confirmed. Booked and immunized at Kelembakam PHC. NT scan was taken and was found to be normal. History of folic acid tablet taken regularly. No history of abdominal pain or bleeding PV. No history of radiation exposure, any other drugs intake. Basic blood and urine investigation was done and found to be normal. GCT was done and it was 98 milligram per deciliter. Her second trimester, quickening was felt at 5 months of amenorrhea. Anomaly scan was taken at 21 weeks and found to be normal. No history of abdominal pain or bleeding PV and discharge PV. No history of increased frequency of micturition. Iron and folic, iron and calcium tablets taken regularly. Injection TD 2 doses taken. OGCT was done at 22 weeks and found to be normal. Her third trimester, able to perceive fetal movements well. Iron and calcium tablets taken regularly. Growth scan was done at 32 weeks and normal. No issue of lower abdominal pain, bleeding, PV. No history suggestive of gestational diabetes mellitus or gestational hypertension. No history suggestive of urinary tract infection. Past history, there is no significant past history. Family history not reliable, ma'am. Can I change?
Yeah. 1 second.
General examination, patient comfortable at rest, moderately built and nourished, not anemic, not eccentric cyanosis and clubbing, no pedal edema, both breast clinically normal, thyroid clinically normal, spine clinically normal, and height 153 centimeter, weight 67 kg. Okay, vitals, pulse, BP, everything is normal, ma'am. Systemic examination is normal, ma'am. Perabdominal examination, inspection. Shape of the abdomen is globular and longitudinally distended. Umbilicus is central and everted. Linea nigra striagra abdomen is present. No scars, sinuses or dilated veins. Hernial orifices are free. Palpation. No local rise of temperature. No tenderness. Uterus corresponds to 36 weeks of gestation. Symphysis of fundal height 36 weeks. 36 centimeters corresponding to gestational age. Pal- Leopard maneuver, frontal grip, a sound, broad, irregular mass, not independently palatable, suggestive of breach. Lateral grip, left side, smooth, curved, hard, uniform resistance, felt suggestive of spine of the fetus. On right side, multiple small nodules, felt suggestive of limbers. Paulic Poglis grip, smooth, hard, round mass, independently palatable, suggestive of fetal head, occupying the lower pole of the uterus. Second pelvic grip, hands are diverging, head is engaged. Centipede is higher than the occiput, vertex presentation. So average size baby, estimated fetal weight of 2.8 kg, clinically like a adequate. In auscultation, fetal heart sounds present in the left spinal umbilical line, ranges from 140 to 148 beats per minute, regular. For speculum examination, cervix appears normal, draining PV is plus, pooling of draining spooling in the vagina. Per vaginal examination, cervix unapaced, mid position, medium in consistency, as 1 centimeter dilator. Membranes are absent, head at -3, pelvis adequate, clear racket draining PV mums. Bicep score 3 by 13 mum.
1 second. Chitrakala, can you mute others other than myself as well as Tendral? Chitrakala, because we are getting little disturbances.
Deepa madam, I think Tendral's mic is only having disturbance. She
Oh,
is presenting from the hospital
hospital.
only in the ICU.
Okay, then
Tendral,
it's
Okay,
okay.
where
ma'am.
are you presenting from, ma?
Yes, ma'am. I'm in ICU, ma'am.
Oh, okay.
Room la irundhu பண்ணாங்க. There is a
Duty,
message.
ma'am. Night.
சரி. Okay,
Disturbance
okay,
in
go
the
ahead.
இதுன்னு சொல்லி போட்டிருக்காங்க. Talks in the background. ஏதாவது ஒரு ரூம்ல
Okay,
இருந்து
ma'am. I'll
பண்ணுமா?
change. Okay, ma'am. I'll change, ma'am.
68 பேர் லாகின் பண்ணிருக்காங்க. Only your mic is
Okay.
under problem.
Okay, ma'am. I'll change. Yes, ma'am.
Yes, ma'am.
Continue, ma.
Yes, in perpetual examination, cervix sunapaced, mid position, medium consistency, os 1 cm dilated, membranes are absent, edit -3, pelvis adequate, clear like a draining, ma'am. Modified bicep score 3 by 13, ma'am.
Okay, now. This is your
K.
summary.
Murray. Yes, ma'am.
Mm.
Mrs. X, 25 years, wife of Y, homemaker belonging to socioeconomic class 4, coming from Chengalpet, primary, with 9 months of amenorrhea, booked an unit at Kelambakam PHC, gestational age of 37 weeks plus 1 day, with complaints of draining PV since 1 p.m., 3 hours before admission. Her BP and pulse rate was normal. No significant family history with normal general examination, systemic examination, obstetric examination findings showing uterus corresponding to the gestational age, single life fetus, a longitudinal lie of cephalic presentation, and a fetal heart rate of 140 to 148, average size baby, estimated fetal weight of 2.8 kg, with clinically adequate liquor, probably a case of premature rupture of membrane, has now come for the further evaluation and management.
Mm.
Next.
Okay. So your diagnosis in a nutshell is like it's a primary, very absolutely low risk. Now it's 4
Yes,
hours,
ma'am.
3 hours of rupture membrane, correct?
Yes, ma'am.
So rupture membrane, do you diagnose is clinically or as well as ultrasonogram?
It's by clinically, ma'am. Clinical and as well as ultrasound, ma'am.
Ultrasonogram. Why ultrasonogram is needed?
For
So
confirmation, like her status, ma'am. We are
why
checking
like a
like her
status
status.
is needed? If you have a low risk mothers, absolutely have all the growth scan is right, and clinically you did a
Yes,
speculum examination and there is a like a pool. So
yes, ma'am.
probably that itself is diagnosed for your rupture of membrane.
Yes, ma'am.
Okay. Okay. So what will be your further management? How did you progress afterwards?
Ma'am, doing basic investigations, ma'am,
Okay.
and doing high vaginal swab culture sensitivity, everything, and
Okay.
doing
So
admission time NST, ma'am.
okay, NST. So whenever, as soon as your first initial assessment is clinically, and clinically you confirmed is a primary low risk, 37 weeks, 3 hours of PROM. So your next immediate management is you need to see the baby and you have to rule out any ongoing infection.
Yes,
So
ma'am.
for ongoing infection, what is the test you needed it? So you have done blood counts, urea creatinine
Yes,
is
ma'am.
a
Total count. I'm checking.
routine things you've done a urea creatinine is a previous investigations.
So routinely doing, ma'am.
So why you did urea creatinine LFT? Justify your other than CBC, justify your investigations. I am okay.
Ma'am, I'm doing urine routine for to rule out any infections, ma'am. CRP also for doing to rule out infection only, ma'am.
Okay. SGOT, LGPT.
Routinely we are doing, ma'am.
Oh, routine. In this case, you justify. I justified because in case of sepsis, okay, it's
Okay,
suppose if
ma'am.
she is already full blown sepsis, probably you have to have your her LFT, urea creatinine, serum lactate, and other things. But initial investigation, your CBC, CRP, urine routine is enough. Okay.
Okay.
Okay. So you also did ultrasonogram. You just present, start
Yes,
present
ma'am.
now. Sorry, start present your ultrasound.
Yes, ma'am. SLAUG, cephalic, placenta anterior, not low lying, like 6 cm, ma'am. Scan GA 36 weeks plus 4 days, ma'am. Her Doppler is normal, ma'am. CPR more
Okay.
than one.
This ultrasonogram gives you any other extra findings for you to do further proceedings.
Yes, ma'am. Like a status, ma'am.
Like suppose if liker is like 1 centimeter, you won't do normal delivery.
1 cm, ma'am.
Mm.
Yes, ma'am.
Okay. So so we'll move on to the next one. So
Okay.
actually, liker is as long as your CTG is fine, your NST is fine. You really don't. If you have a recent growth ultrasonograms, really you don't have to waste time in doing an ultrasonogram for a
Okay,
PROM
ma'am.
case. It's a primary. Okay, but
Okay,
you are
ma'am.
justified by seeing and especially a fluid volume, correct? So you are
Yes,
also
ma'am.
justified, but the guy most of the guideline doesn't recommend immediate ultrasonogram. Okay.
Okay. Okay, ma'am.
Mm. So now your admission CTG.
Yes, ma'am.
So why you
NST at
do
the
a
time of
admission
admission.
CTG? Why you do admission CTG? What is an indication?
From patients in PROM, we have to check the fetal heart rate status, ma'am.
Mm. So you did an NST. So what is an
Yes, ma'am.
advanced? You did an NST. Just so NST is reassuring.
Sorry, ma'am. Yes, ma'am. Reassuring.
Okay, proceed. You just explain the findings.
Yes, ma'am. It's NST is at the time of admission. NST is reactive, ma'am. Basal heart rate is between 140 to 160, ma'am.
Mm.
This accelerations are seen, but no decelerations. Uh,
No deceleration. So reassuring. So what's the plan?
yes, ma'am. Ma'am, patient is in term and just adequate like you're planning for induction, ma'am.
Okay. So induction now or later? Immediate or later?
Immediate, ma'am.
Immediate. Why do you want immediate induction?
Ma'am, because of to prevent infection and just adequate liquor, ma'am.
Just
To
adequate like a
deliver
matter. Okay. So in a primary, it's a term leaking membrane, so PROM. So you are justified doing an immediate inductions. Probably within 24 hours, you have to
20
start
hours.
induction as early as possible. There is no expected line of management. The reason is,
Yes, ma'am.
as you wait, there is increased risk of 1 to 2% chances of chorioamnionitis in.
Choriamnitis.
Okay. So probably you have to induce earlier. The chances of increasing chorioamnionitis infection is high. That is why. So proactively you are going to index by reducing the chances of further immunotherapy. Sorry, someone is backing on.
General, I hope you
Yes, ma'am.
understand, ma. 74 people have logged in. You
Okay.
should have taken care that you should have sat in a place where there are no background noise. It's difficult for people to
Any duty
concentrate. If you
doctors
can
room,
move into a room,
One second.
it'll be really nice, ma.
General?
I think she's moving into another room, madam.
Okay, we'll wait.
So in the background, they have posted answers like Manjula has posted by doing ultrasound presentation and cord how many times around the neck can be confirmed. Can you give prophylactic antibiotics? That is another question they have raised.
Hmm. So we'll come to that. Now only we started anti. Okay. So is that antibiotic is leave it to individual protocols, is a hospital protocol. As such, if the membrane ruptures, you don't have to, unless otherwise you have already, she have urinary tract infection or group B streptococcal infection, which has been proved, then you need an immediate induction. Hello? General, you
Hello,
are
ma'am.
still troubling, General.
Ma'am, now okay, ma'am.
But still have a lot of voice backgrounds outside. Maybe you could have used the AirPod.
Yes, ma'am.
Yeah,
I'm using my
earphone or
AirPod
go to
only.
the duty room, ma. Ma, duty room இருக்குல்ல, go to the duty room. Ground floor duty roomல நல்லா net எடுக்கும். Please go there.
Okay, so antibiotic, there are options like you can use your hospital protocol. Most of the hospitals, like as soon as the membrane ruptured, they will be giving a prophylactic antibiotics. There is nothing wrong in that. But first 18 hours, there is no need, 18 hours of PROM, really there is no need for antibiotic. So that is how. So, but individual protocol is also placed in India. Probably most of the institute have prophylactic antibiotics. So antibiotics is okay, but actually no need first 18 hours. So it's only 3 hours. Even if you start an inductions, there is no need for antibiotic. Her WBC count is near normal. CRP is fine. So there is on urine routine is only a trace. So no ongoing infection for her. Tendal, are you ready? Okay.
Yes,
Anyway,
ma'am. Yes, ma'am.
you move on to the next. So you decided for induction of labor. And did you give any antibiotic? That is what the question is. What is the hospital protocol?
Yes, ma'am. We have given, ma'am.
Given antibiotics. What antibiotic?
Yes, ma'am.
Why immediate or
Injection ceftriax.
after starting induction?
Before starting induction, ma'am.
Before starting induction.
Injection ceftriax in 1 gram. Yes, ma'am.
Okay. So if the if your any of your investigation says any infections, will you start induction?
Ma'am, her total count was normal only, ma'am.
Here it is okay.
CRP.
I'm asking the other way. Suppose if there is a high total count or a
Yes,
CRP is
ma'am.
high, what is your protocol? Will you defer by inducing her or
Ma'am,
will
checking for a beta streptococcus positive growths are in a high vaginal swab or urine culture. We are following ACOG guidelines, ma'am, recommended for
okay. It's
antibiotics.
fine, da. I'm just my question is like if your WBC is high and CRP is high, okay, and she
Yes,
is
yes.
leaking. Or so I can put it another way. The CTG shows tachycardia. signs of sepsis, some kind of signs of fetal tachycardia, which is a sign of subclinical chorioamnionitis. Do you proceed? What do you do? Okay, so that we'll discuss later on. So if probably if you have any kind of sepsis in going on, this is by inducing her, you are causing more trouble for the baby. So you won't induce
Okay.
her. So you have to control the sepsis, and the safest way, how the safest way the baby could be delivered, we could have delivered. Suppose if she is 6 to 8 centimeters, you deliver vaginally. If he is not favorable for planning induction, the induction should be abandoned. You shouldn't do an induction. So your admission CTG is fine. Your background investigation is fine. You started inducing, correct?
Yes, ma'am. Yes, ma'am.
So how many hours later you started inducing?
After 1 hour after
So
admission, ma'am.
4 hours of after PROM you admit
Yes,
induction.
ma'am. Yes,
So
ma'am.
this is pre-gel CTGs. Okay. Are you
Yes, ma'am.
happy?
Yes, ma'am.
Okay,
It's
so I
we
will
have
discuss
to.
the CTG in my paper, my moderator presentations. Okay, so you are happy, your
Okay, ma'am.
baseline is like 130, 150, beat to beat variability, acceleration plus no deceleration. Okay, and
Yes,
this is
ma'am.
here. What is the mode of induction for you? Gel.
Labor natural, ma'am.
Oh, you have put a gel, right?
Yes, ma'am.
Okay, so why gel? Why not other
Ma'am,
method?
ma'am, in PROM cases, as per ACOG guidelines, Foley mechanical dilatation is not recommended, ma'am.
Hmm. Why not meso? Oral meso?
Miso we are not using, ma'am,
Cherry,
in our
okay. But
institution.
none of the cases you're not using because it is
Yes, ma'am.
not licensed drug. Okay. So that
Yes,
is why your only option is you have only gel. So you
gel.
have put it every 6 hours gel, correct?
Yes, ma'am.
Okay. So you applied and this is second induction CTG.
Yes, ma'am.
Okay. CTG we'll discuss later. This is morning, correct?
Yes, ma'am. Yes, ma'am. Morning 6 a.m., ma'am.
Okay. And this is the progress of labor. From morning, within 3 hours of starting the labor, the can you just describe the partogram?
Yes, ma'am.
Just describe the partogram. From morning 6 o'clock, it is you started putting the partogram because it is 4 centimeter, correct?
Ma'am, 6 o'clock started a symptom, ma'am.
Okay.
At 8:30, patients in cervix well is 4 centimeter, ma'am. So Partogram started at that time,
Mm,
8:30.
mm,
At 9:30 a.m.,
mm.
8 cm, ma'am, 6 centimeter dilatation, ma'am. At
Okay.
10:30, it's 8 cm, ma'am. So
Mm.
11:30, it's full dilatation, ma'am.
Okay. Okay. So full dilatations and result is also perfect and you have a contractions, good contractions. The maximum dose you have given of
32 drops per minute, ma'am.
32 drops. So as per the guideline and you use ringer lactate. Okay. And these are the parameters of the mother. Okay. Urine
Yes,
acidity
ma'am.
you have checked regularly. Protein also you checked and urine output also you monitored. Very good. So this is the partogram you will be using, and here the obstetric scores. Fine. So what is advantages of using the labor care? In this case, you have used this tendril.
Yes, ma'am.
So the
Ma'am,
outcome.
labor care guide, we
Uh,
can we can mention about rupture parity, patient parity also, ma'am. Labor onsets whether spontaneous or induced also we can mention in section 1, ma'am.
the most important thing here is like the discussion with the patient. Have you discussed anything to the patient? You decided everything,
But
correct?
opinion, yes, ma'am.
You decided everything, first of all. Even when she came with came for induction, you only decided. You didn't even ask. That's most things. So, is the patient is willing? Is he consented for induction? Did you explain the procedure for the consent of
Yes,
uh, induction? Told.
yes,
So whatever it is, this is your summary. I will just sum up. You have a good outcomes, a good progress because your active labor from 8:30 to 11:30 is almost full dilatations, and labor progress you use with traditional partogram. Okay.
Yes, ma'am.
So
Yes, ma'am.
when you diagnose PROM, it's only a clinical confirmation of clear liquor. There is no need for vaginal examination in a term PROM, any PROM. Okay.
Okay.
Ultrasonogram, someone is mentioned that she has to look for the cord around the neck thing. See, this is 37 weeks. If she is going to progress for cord around the neck, see what everything will be as the labor progresses, we will come to know. So if you already have a scans, the growth scans, which is around 32 to 34 weeks, it doesn't have a cord around the neck. Right now, doing an ultrasound to look for it is not necessary. Position or anything is not necessary in the beginning. Probably the intrapartum ultrasonogram, some centers is using if they have a poor progress or if they found out. So you justified in these investigations, CBC, CRB, SWAP, CTG. CTG itself, your admission CTG, if you put, it shows a tachycardia, then that itself will show that there is a sign of some subclinical infection is going on. Okay, so your CBC,
Okay.
CRB is an additional value. SAM, swab amniotic fluid culture, they have to wait for 48 hours. Only you can do a gram stain immediately to look for any bacteria is there. Okay.
Okay.
So justification, the question I ask is like the risk of chorioamnitis increases significantly after 18 hours. So that is why within 24 hours, as soon as possible is also fine. Your almost all guidelines says as early as possible. So wait for some more time for spontaneous progress. If no progress, okay. And methods of so that is what nice is. Whenever you do something, you just see guidelines. Guidelines almost everyone preferred in immediate induction over the expectant management. That is within 24 hours. Your labor card guide, especially you have to start document if active labor has been established within a reasonable time post PROM. So either induction or oxytocin should be done. Role of antibiotics, someone is asked, no routine. Yes, you needed if there is labor is prolonged or as per your hospital protocol before induction of labor. And definitely you need an intrapartum prophylaxis if you already have group B streptococcus colonizations or previous baby or intrapartum any fever or if the rupture of membrane is more than 18 hours and the antibiotic depending upon your local hospital protocol you can use it.
Okay.
Okay. On the choice of induction, cervix is unfavorable since you don't have a mesoprostol in your loop. You are not able to do it. Balloon catheter in settings where prostaglandins are contraindicated is still yes. And if you recently after 2021, if you see your ACOG, WHO, Cochrane, they started supporting sterile insertion of balloon catheter in PROM because the risk of infection in balloon as well as PGE2 gel when they compare the gel has more infection rate. So as since it is nothing available for you, you are justified in using PGE2 gel and misoprostol is the way forward. WHO is started telling the misoprostol and only thing is in PROM avoid vaginal misoprostol. You can start giving a oral 25 microgram every 2 hours or 50 microgram every 4 hours. Okay, so MISO is WHO's and ACOG's. ACOG is like a off-label use. WHO is scarf for it. Okay, gel is like it is washed away. If the lack of membrane means the gels gets washed away, there is slight of infection risk is high. But nice RCOG guidelines doesn't say anything about prostaglandin, gel or meso. Meso is not in the loop. But they say only prostaglandin. So whatever the prostaglandins is okay. So when I use a polycatheter, vigilance of infections, fever, CRP trend has to be there. Okay, this is one nutshell. And this is again a nutshell of poly. You have only these three options. Poly is out right now. The evidence is not favored, but Cochrane ACOG start having poly. So you have an option between meso and gel. So most important thing is you have to talk to the patients, whatever you are, and document the patient's concern. Okay, so that is most important. Now coming to the CTGs. So the CTG is like before telling your commenting on your CTGs and what is the CTGs future CTGs you will be having it. So this is the prerequisite of any CTG you have to have. Your CTG paper should be set at 1 centimeter per minute. Okay. So at the ensure the date, time are correct on the CTG as well as the machine. So every time when the machine has been come, they mention as 3 centimeter per minute. Okay, so if you see a 3 centimeter per minute, 1 minute you will be having 3 big squares as 3 centimeters, and your extended paper only you will be saying. So coming back to the your CTG is actually a 3 centimeter.
Yes, ma'am.
Okay. So how I identify the CTG is because they have given the numbers here, time. So every this is every 2 minutes. So almost, so this is actually your 1 minute.
Okay.
Okay, what you are seeing in 1 centimeter, you will be seeing this much. Okay, and
3
every
centimeters.
time if you see like that, so total is only 8 minutes you are having. We cannot interpret any CTG in 8 minutes. You need at least 20 minutes of CTG papers. That means you have another threefold time of papers you will be having to interpret this CTG. Okay.
Okay.
Okay. So that is one more important thing, the paper setup. And you see your time, your date of time is like 25/4, and what they have mentioned here is different. So when you have a medical
General, general,
certificate,
ஒரே
Yes,
நிமிஷம்
ma'am.
தீபா மேடம். தீபா
yes,
மேடம்,
yes,
ஜென்ரல் ஓ
Yes,
மைக்
ma'am.
ஆஃப் பண்ணிருமா.
Okay.
மேடம் மட்டும் தானே பேசுறாங்கப்பா, மைக் ஆஃப் பண்ணு. பீப்புள் ஆர் ஜஸ்ட் புட்டிங் மெசேஜஸ், பேக்ரவுண்ட் நாய்ஸ் இஸ் வெரி லவுட், unable to focusனு. மேடம்
okay,
பேசும்போது kindly put your mic off மா.
yeah,
மேடம்
better.
மேடம்
Then you switch off the phone.
டிஸ்டர்பிங்
Then
மேடம், கவனிக்க முடியல.
Cherry.
தேங்க்யூ மேடம்.
Okay. Okay. So this CTG, when you see, it is only a 3. The setting is only 3 centimeters. So you will be having extended things. You can, the baseline and accelerations will not be altered by in 3 centimeters, but when your variability is totally, we cannot able to see what is the total variability. And second thing is to interpret, at least you need 20 minutes trace. Here we will be getting only 8 minutes trace. And whenever you say the CTG baseline heart rate, start writing the numbers. Do not write it a range. Okay. Why the range should not be there? Because the original baseline heart rate has to be mentioned. Okay. So in 1 hour later, if you see the if you see the CTG and there is a rise of 20 beats, suppose you will be having 140 in the beginning. Okay. And 160 after 1 hour later. So what happened? It is come as an amber color. That is, it is suspicious. The baby's heartbeat has been started increasing from the baseline to 20 beats high. Though 160 is normal, but baby is being increased from the baby has showing tachycardia. So it's some compensatory mechanism is happening. So you cannot write one in a range. Always write in a original baseline heart rate. Okay. Then only we can see there is an increase in heartbeat rate, and after 1 hour reassessment, we will able to do it. And here also, when you see CTG of 3 centimeters, most of your CTGs, you need a baseline heart rate. To read the baseline heart rate, you need at least 1 centimeter or at least 1 minute. 1 minute. So here 1 minute stable heart rate. So even if you here take a baseline heart rate here, this is almost like a 1 minute, or not even 1 minute. It is like a 1, 2. Almost 1 minute is 3 centimeters. It's less than 1 minute here. So at least you need a 2 minutes paper to see the baseline heart rate. So in this 8 minutes, though the baseline heart rate seems to be here, we cannot correctly tell this is the baseline heart rate. So it's actually indeterminate. You have to continue the CTG. So the baseline heart rate is more important. And for example, these are the parameters you have to see in the any kind of CTG. So variability is 3 centimeter to 4 centimeters will be confusing. So this is how the 3 centimeters paper will look like. So this all is 1 minute, but this is almost like a for 5 minutes, almost like a 1, 2, 3, 4, 5, 6, 7, 8 minutes trace. So this is almost like a 1.5 minutes trace. So this is 8 minutes trace, is 1.5 minutes trace. So you know the difference. Why no that you shouldn't read in the 3 centimeters paper. If you want to read a 3 centimeters papers, you have to have a broad. So what the zigzag appearance of the variability, which is a good variability, looks like a reduced variability. So that's the most important thing wrong in the CTG machine. So once you got a CTG machine, set up the thing. So this is a fast speed. So you will be having a heavy things, variability appears smoother or dampen. And if the variability is, invariably you say that the baby is sleeping. But actually the babies, if you set the machine into 1 centimeter, this is how the babies looks like. So variability is absolutely normal. So it is a more stretched paper. Paper is getting wasted. The variability is probably the clinician perception will underestimate the variability in 3 centimeters, which is moderate, which will be even moderate variability will show abnormal variability. So the paper speed is most important. And the most important thing we will miss in the 3 centimeter is the cyclicity. Cyclicity is the period of sleep pattern for the baby. Even during labor, when the baby is think, there will be a period of altered sleep pattern as well as a good variability. So this says the baby's central nervous system is absolutely normal. So there is no hypoxia going on the baby. So this is another reasons. This cannot be seen in 3 centimeter paper, whatever the paper you see. Okay, this is again a prolonged sleep pattern. So you cannot stop it. You'll continue it. Towards the end, it started having good variability. So even the contraction is there. The baby won't sleep means, baby is sleeping means it's a good. If there is a hypoxia, the baby won't sleep. Baby have know there is a hypoxia is going. I have to be very awake. So the heartbeat will be there. So this sleep pattern is more important. And so always have this pattern of having the CTG, find all these features in a CTG and describe it as a good, amber, red, and categorize whether it is a normal CTG and suspicious CTG and pathological CTG. Okay, if you have the thing, then this is taken from the NICE guideline. So baseline heart rate, variability, deceleration has to be mentioned exactly, has to be read exactly like this. And then you can even use Dr. C. Bravado. Coming back to Tendrel's case, so this is most important. They ensure the date and time are correct on the CTG. Check date and setting the case CTG machines is validated. Make adequate paper. At least 20 minutes is required. So all the CTGs which is I am going to show is almost all the CTGs is only 8 minutes. Okay, so coming back to the case, the defined risk in the case is PROM, average baby size, and induction of labor is a reason for CTG continuous, and contractions initially nil or mild. This is admission CTG I'm reading. The exact number is 145. It is not 140 to 160. The variability is reassuring. Acceleration is present, variables are none, and I'm just reading the 3 centimeters, 8 minutes papers. So this is a reassuring trace. It's suitable for induction. If it is not reassuring, if it is a tachycardia, or if there is a continuous sleep patterns for a longer time, or if there is a deceleration, this baby is not suitable for induction of labor. That is the importance of doing an admission CTGs. So once your CTG is done, then you have to document your labor. So you can use your WHO Partogram, standard hospital Partogram, LCG. There is nothing to document in the latent phase. So you can use record of time of rupture of membrane. That has to mention only in the LCG. If you see the LCG on top, you will be having a rupture of membrane. When the rupture of membrane happened, that they gave the importance for rupture of membrane. So that's why slowly you have to move on to the labor guideline. When you start induction of labor, start the cervical changes, only do PV to see the cervical changes, not unnecessary PV. If the contraction is frequent and if she is having evidence of progress, then you do. So monitor the maternal vital CTG urine output. CTG should be continuous only in active labor, not in induction. Induction, when there is no contractions, then you go for intermittent auscultation or intermittent CTGs every 4 hours or pre and post gel CTGs. And every 1 hour assessment, fetal heart rate by Doppler, like a color, any foul smelling discharge, maternal vitals, which these are the things in preterm PPROM gives us a clue is that sepsis is going on. Avoid vaginal examinations. Look for signs of infection, fetal distress in the CTG. Also, you have to know how to pick up. This is pre-induction gel CTGs. So the one which is causing the uptrend isn't what she marked isn't actually we can take it as an acceleration. Again, this is only 8 minutes trace, 10 minutes trace of paper. Okay, but overall, the baseline heart rate before induction is 135, and there is an acceleration as there. Variability, we have to imagine it is a 1 minute is 3 centimeters. So this much is a 3 centimeter. So here you have to imagine this much is a 3 centimeters. So this much is a 3 centimeter. So imagine there is up and down is happening, but it is little flatter. If it is shrunk, it will be more flatter. So variability is almost more than 5 beats per minute. Here it is again or pre-induction CTGs, her CTG one only. So you have to slowly modify how difficult it is to see the baseline heart rate itself and the variability itself. Here again, don't make the mistake of putting a baseline heart rate of 130, 150, put it. So whatever, this is where the baseline heartbeat will be there. So it is 3 centimeters, 1 minute. Actually, we need 2 minutes to read the baseline heart rate. Between where to read between two acceleration or between two decelerations. Say in between two contraction only you have to see it. Okay, there is no contractions here. So here and same it is also and reassuring heartbeat. Here baseline heart rate is indeterminate. It's a pre-induction again gel. So whenever you have a pre-induction gel, when you cannot able to see the baseline, you have to stop inducing. You have to document, and in indeterminate, you cannot able to determine baseline heart rate means this is whatever I am putting. It's only a half a minute. Half a minute we cannot say this is how the baseline heart rate looks like. Not even half a minute. It's almost like 2 centimeters, so less than half a minute. Okay, so we cannot read a baseline heart rate there. You have to continue the CTGs and see the baseline heart rate. Again, here also we cannot read the baseline heart rate, and this is before starting Synto. So Synto, this contraction is also, it's appear as a jagged appearance. So one thing in the settings of CTG, you have to put a baseline contractions here. There is a 20 settings is there. You see, it has to come 0 setting. Then only the contractions start from 0 and go above the 20 settings. Okay, so this has been set into the above the 20. That is the reason the contraction is not relaxing. We cannot able to see. Again, this is again a 3 centimeter paper. So you cannot see the proper contractions as you see in a 1 centimeter per minute paper. So, okay. So if you see on top, you can see the rupture. In this section, you can see the, it's a labor card. You can see the number, time when the, sorry, time when we can see the rupture of membrane. So that is how. So the same thing if you use it here, latent phase, her uneventful, her induction period, she within 2 doses she's progressed to active phase in the morning, almost 8 hours she progressed, 8 to 12 hours she's progressed good, and she could able to start active labor at 4 centimeters, start syntosina. So one is that maternal identification informations in the first session, supporting care. This is missing in the traditional partogram. This is very important. Those who attended yesterday's webinar, you come to know that in detail about this. So you need a companion. If it is N, it is actually red, and you need adequate pain relief, and the position should be patient should not be in a supine position. Even Synto is there, either sitting position or anything other than supine position, it is good. Okay, so all those things has to be monitored in section, and supportive care of the baby also. If you see the this partogram, in that whole partogram, it's only the CT fetal monitoring has been there. Rest of the things we have to search. But if you see the care of the baby, you can see the meconium, you can color of the liquor, you can see the fetal position, you can see the caput, you can see the molding. All the parameters has come into the care of the baby. Again, care of the woman, you can see all those things like maternal vitals, temperatures, or temperatures. In this case, it's very important, the pulse, temperatures, BP, is he developing any tachycardia or anything. Labor progress, it's not very with the traditional things, but only thing is like the hours. So the patient, there is no time limit, there is no time restrictions. And one thing I have to ask Tendril is like why she has done when there is a good progress, why in a background of PROM, why hourly vaginal examination that could have been avoided. So as long as the fetal continuous CTG has been put, you can just monitor on the CTG and see how she is pushing. When she is pushing, when started crowning, probably you could do the vaginal examination. You could have avoided all this 4 hours hourly vaginal examination. Even your traditional guideline says only 4 hours. As there is no maternal concerns or fetal concerns, no need for any examination. As long as medications, probably you can give whatever missing is like we could have put a gel, oxytocin, and other things. And the shared decision making, of course, traditional thing. So strength is like here the strength is coverly PV is not always justified. Only PV is justified if you felt that there is any developing any poor progress or any CTG abnormality or any color change of lichens like meconium or anything. So active phase duration seems acceptable. So what in this tendrils CTG, she could have avoided that alone. Otherwise, it's need completeness. So in LCG, the documentation of fluids, positions, pain relief companion will be good. Identification of admission details, as I said, the rupture of membranes and identification of 4 centimeters, not at admission for PROM, but PROM timing has to be mentioned. Then only we know the time clock. So if it is more than 18 hours, if from the time of PROM during the process and active labors, if more than 18 hours, we know that the chances of infection is high. Okay, supportive care, so companion present could be recorded from that promotes a respectful care, oral fluids, mobility, bladder care. She has mentioned she's having a correct urine output was normal, fluids has been taken, but in labor care it has been even during encouraged in induction as well as early labors. Pain relief options, especially if you are using oxytocin, probably you have to use some kind of a paracetamol, tramadol, or some kind of pethidine, whatever it is, early labors or late labors, you can use a gas or epidural if available. If since she is having a quick progress may not need a much of pain relief. Okay, so relevance in this case is like she has progressed, so would be charted here. Appropriate during induction, and if oxytocin is used, you have to use continuous CTGs. And meconium stain lichens, no clear licher. If there is no licher is also, it's an abnormal, so would be checked in this session. Scare of the woman, as I'm just elaborating the LCG guideline here, comparing to this, in pertaining to this case. So in this case, probably you could have document BP 4th hourly, pulse hourly, temperatures, vaginal examinations with indications. If you are doing a hourly vaginal examination, this is crucial. This should discourages, LCG discourages routine hourly PV. This is crucial in PROM to reduce infection risk. Labor progress, very good, excellent. There is no much of change. Since the progress is very good and the heartbeat is main, CTG is fine, that's fine. Okay, okay. So basically she has used antibiotics. She has 2 doses of gel, oxytocin used, and infusion charts it fits in. Only missing is like shared documents, woman's preference, counseling. Suppose if the lady doesn't want a induction itself, then we need a proper counseling. Why need an induction? Any questions, Meena? In the chat box. Deshi ma'am, did you join?
Yes, ma, I've been here for about 20 minutes now.
I know, ma'am, please. Okay.
Oh, no, I think excellent discussion, but just a couple of points which you have already stressed on. The fact that CTG, we have to be sure of all the details that you brought out about the paper speed, etc., before we start commenting on it. And every time go through the parameters one by one so that we don't miss anything, no eyeballing of the CTG and giving a comment. And then the thing about the PVs, I thought Bob brought it out very well. Very often we find when one shift is changing over to another, they feel compelled to do a PV, which normally itself is not required, but in a PROM, definitely we should be very, very careful. Look and see when it is, or do a PV only when there is an incident requiring a PV. like wanting to go for analgesia, etc., then you do a PV earlier. Otherwise, you stick to the rules, don't have to do it earlier. And PROM especially, be very, very careful.
Yes, ma'am.
The patient is not willing for induction.
That's most important.
Mhm.
Okay, we have to either convince her, suppose, but we have to respect her autonomy. So probably I would, if she is not willing, I will document. That is the most important thing. Second thing, I will respect her wishes. Despite of my detailed counseling of infection risk, she aware of it. We'll wait for more than 24 hours. Do the CTG 6th hourly. Do the blood works. Look for signs of infections and review her as necessary. Probably she will change her mind.
But we can't really sit back also. We need to be a little proactive in trying to convince her and the family. Because we
Correct.
know what is going to happen the longer we wait.
Mm.
So we can't just leave her. It's not like I don't want induction. We are advising induction for a particular reason in this case. So we need to definitely talk to them a little more.
Not more than 24 hours.
Yeah, that we need to tell them why we are advising it. And then if they still take a call, it's different. But as you said, document it. Please document whatever you're saying.
Mina, anything in the chat box? I couldn't able to see the
Yeah,
chat.
Indra wants to know indication for PV during labor. In any labor, Indra, or is it you want?
Any labor is okay, ma'am. Or it is PROM particularly when we want to do PV, like 4th early we'll be doing. Suppose we want to do in between. What are the time we'll do a PV for the postgraduates function?
Okay. So as per the guideline, it's only a 4th hourly CTG, once 4th hourly PV. Once you are entering into the active phase, in a pre-latent phase, there is no need for PV at all, unless otherwise you are documenting a 3 contraction in 10 minutes. You want to proceed for augmenting her or inducing her, then probably you need a PV. So active labor restrict to a PV is 4 centimeters especially for 4 hours. So the guidelines clearly says if you have any changes in the CTG patterns, if you have a suspicious CTGs, then you do a PV, assess the progress of labor. Is there any kind of prolonged signs like CPD, like caput molding or dehydrations, and then any color change of the meconium or bleeding, then probably for that reason only CTG changes, we need a PV. Second things, before 4 hours, for 4 hours, if the mother is unusual, you might be having some bedside clues, like unusually she'll be shouting and she'll be draining, exhausted, moaning. Then we know whether she is she have in what way, what progress is there. If she is having a prolonged course, probably you can give an epidural before epidural, so that if the labor process is going to be exhausted for her, you need to cut short it by giving a pain component. Then that time you will be doing a PV. I don't think so. Unless otherwise CTG changes, you need an earlier PV is needed.
Just one more word I would like to add here. The diagnosis of contractions, diagnosis in inverted commas, you have to be very careful. It's not what the CTG shows. It is, you have to palpate. It's not if the woman screams, it's not what the CTG shows alone. You have to palpate and recognize the contraction, learn to recognize it. The other question is active labor starts at 4 or 6 centimeters. What's the normal sleep cycle of babies? 45 minutes in CTG. I think this 4 to 6 centimeters is kind of a debate going around. Many years ago, it was 3, then it became 4. The labor care guide, is it 5 centimeters, Deepa?
5 centimeters.
Yeah. So LCG says 5. But I think the more recent, some of the literature is even saying 6.
So nothing wrong in starting a partogram at 4 centimeters.
4, yeah.
Okay.
Definitely
Because
don't start it too early, because obviously you know that you're not going to do any intervention earlier than that.
Just for the monitoring purposes.
40 minutes is what is normally quoted as a sleep cycle, but you have to take into account other factors also. Have you given any medication? Any opioids have been given? So we need to take all that into consideration before you decide that 40 minutes is the limit for sleep cycle.
And if patient is not feeling, what advice? I think that has been answered by madam. Background noise is very loud.
No, somebody.
The mother is present with fever with PROM. We have to treat the mother.
Yeah, I think that's very important. We need to keep that in mind. So, I think Latika has asked, ma'am, we have to use speed 1 centimeter per minute or 3 centimeters per minute. I think Deepa has really dealt in detail why we should actually use 1 centimeter per minute. It's important. She's really given you all the reasons why you should do 1 centimeter per minute. And if Latika wants to, I think you should now tell us what you understood from Deepa's talk.
Yeah, Latika.
Latika? Because she has given a lot of detail.
3 centimeter, I'll nutshell. 3 centimeters per minute means you, for the CTG paper to read, you need at least 20 minutes trace. So if you are using a 3 centimeter per minute, then you will be having an extended paper to read it. And then only reading you will be seeing is a baseline. Baseline also, for the baseline to read, at least you need 2 minutes. So 2 minutes means 6 centimeter paper to read only a baseline alone. So how can you justify in interpreting a CTG? And then the most important thing is what appear as a moderate variability is appear as a stretched and sleep pattern in 3 centimeter. So, that is also not possible. Okay, so that is the reasons. Make it a habit of 1 centimeter per minute. You won't be wasting the paper. That people are putting in the monitor and just to see the CTG. If you are putting in the monitor, then that is also has to be stored. Then there is no point of doing that monitor CTG alone. That is another point, because I asked Tendril why you are having a bit of papers, why you didn't use a continuous CTG. She said, I used a continuous CTG, but I saw only in the monitor. But the monitor was not stored. So then that it is not digitally, it is not possible.
No, and also you need, Noma, suddenly you get one big D cell. You need to have that documented. See, that is why the indication for continuous CTG in certain situations. So we need to have some record of it, or you need to have paper going. And when you start using 1 centimeter, you will be using less paper. So I'm sure you'll be more inclined to use the paper rather than the monitor.
High vaginal swab in terms PROM, is it a must? I put a question marks, but none of the guidelines say that for a term, you doesn't have to have actually culture and sensitivity. Because by the time before that, we will be anyway inducing it before the results comes. But preterm, yes, you need, because you need to know what is the reason for the preterm PROM.
Okay, the next one is a good question. If signs of chorioamnionitis are present at the time of admission itself and Bishop's score is not favorable, whether we can wait for normal progress or proceed with cesarean. I think again here I would say whoever asked the question talk. I think the mother is always more important, isn't it? You probably may not be able to resolve your chorioamnionitis unless you deliver the baby. So definitely controlling all her parameters as early as possible and bailing out will be the way forward in this situation. Is monitor having storage of CTG without paper? Yes, it is. It is available.
You have to document and store with 1 centimeter per minute, not a 3 centimeter per minute, because you will be wasting the lots of data. Okay, so that is also, it is available. You have to properly put an identification of the patient's name, other details in it. Okay, if no more questions, shall we sign off? We'll see you next month. Ma'am, you are muted.
Yeah, I had a call, so I had to mute it. Yeah, I'm back here. It's nice. I think I was joined in late. I'm extremely sorry about that. From next week, from next month onwards, I will schedule my work so that I can join by 6.
Okay, ma'am.
One more question has
One
come.
more question.
Let's see that also better.
Indication of LCS, ma'am.
No,
PROM more than 18 or 24 hours.
no, it is not an indication for only the infection risk is high if it is more than 18 and 24 hours. If the CTG is fine, if your baseline CBC, CRP is fine, and to start off it's an ideal more than 18 hours, you have to start an antibiotic. And if she is unfavorable, you can still induce, or if she is favorable, then you can augment with oxytocin.
And iatrogenic sepsis, try to avoid. By that I mean PVs.
Examination.
Yes, okay. That will be our contribution to it. So that we have to try and avoid. There is absolutely no need to panic in PROM.
There are no more questions, Jayashree ma'am.
Yeah, then we'll go ahead, ma. Deepa,
Yes.
okay?
Okay, thank you.
Yeah, I mean, all
Thank
of you
you,
can
thank you,
continue to keep tab of questions if you want. We are quite happy to answer it, on the group or even on the in the next class. You can always bring in the questions. Don't hesitate to ask. That's what I would say.
Yeah.
One more question, madam. In previous LCS with PPROM at 30 weeks, if we have started neuroprotection and signs of chorioamnitis are present, how is the management plan?
Deliver her.
Yeah, deliver her or go off duty. Yeah, it's very clear, Lama. You have to deliver.
Can we discuss on preferred antibiotic?
There's no question of preferred. That's what is indicated. Guidelines, you have to follow guidelines.
If you have hospital have a local protocol, most
Yeah.
of the institute will be having their local protocols. You have to follow it up, because you cannot unnecessarily use higher end antibiotics, thereby increasing the resistance. So you have to use your hospital follow up here hospital protocol for antibiotic usage. And in our hospital, we will be using first generation penicillin, which is Reflin. And so most of the
One
centers
more
will use
question
the second
from
generation.
Soundarya, whether we can wait till neuroprotection cover, ma'am. It's been answered that we have to deliver the baby.
Yeah.
And as Deepa madam rightly said, it's a hospital protocol based on the high vaginal swab report which is taken, and there will be a policy in each hospital. We need to follow that.
Yeah, and remember, I mean, you don't necessarily have to work in a big hospital with a big policy, etc. Even if it's a small unit, you have your own policy, but you stick to it for every case. The whole idea of the thing is that the bug should not develop resistance. So you cannot give one antibiotic for each case, and you can't play around with it. So even if you're working in a 40-bedded or 30-bedded hospital, have your own policy. And it may change from time to time. Is again something. Usually, hospital antibiotic policies are all revised at least once a year. Or if there's any major outbreak, again it may be revised. Or if it's showing resistance, again it may be revised. So there are a lot of things we need to go into.
So I thank ma'am. No more questions. I have to thank Tendril. Despite of her labor ward duty, she beautifully came out of the case which have a lots of discussion, madam. And thanks Tendril, and thanks Meena.
Thank you, ma'am.
Thank you, Meena also, and Deepa. Thank you.
Thank you, Jayashree Gejraj madam, for your valuable inputs, and Deepa Thangamani madam have brought out all the guidelines, ACOG, RCOG, the latest recommendations. Really like to appreciate madam's effort, and Tendral Raghunath, her guide, Dr. K. Priyadarshini, and we have got good number of delegates who have logged in, and they were having a very good interactive session, madam. Thank you.
I
Thank
saw
you for
84 when I joined, which is, I think, an excellent
yes.
number.
Okay.
Yes, madam. Lot of girls have come in and logged out also.
Great.
Thank you.
Meena, Madhuri madam has asked, she couldn't able to log in, unable to connect. She wanted recording.
Yes, all the recordings of all the webinars. If you are not able to attend, we are planning to release in YouTube shortly, madam. So
Okay.
everyone will have access of all the webinars. So no
Okay.
need to worry, even if you're not able to attend online at that particular time. We'll make sure that everyone gets all the recordings, madam, because every faculty has taken more time and invested lot of time, even being their busy schedule during weekdays. We would really make it possible to happen, madam.
Thanks, ma'am. Thank you.
Thank you. Thank you,
Yeah,
Meena.
thank you.
Thank you,
Thank you,
ma'am.
madam.
Yeah.
Thank you for the excellent platform, and Sampath madam and Meenakshi. Thank you, madam.
Thanks. Thank you, Sri Events, as well as Chitrakala. Thanks, Chitrakala.
Thank you, Chitrakala and Sri Events. Thank you.
Thanks.